Señoras y señores, muy buenas tardes.
Ladies and gentlemen, good afternoon, and welcome to our webinar on nursing post-pandemic, put together by the Catholic University of Chile and the health network UC Christus. I'm Sonia Abad. I'm from the network UC Christus, and I'll be moderating today. Today, we'll be looking at post-pandemic challenges with a special focus towards the importance of care and retention of the nursing team. I'd like to call on the public and the speakers to tune in on YouTube, where this is being broadcast, and on the Zoom platform, in case you do require interpretation to English. Before beginning with the presentations, we'll be explaining the methods we'll be using. Our presenters will speak on their topics consecutively, and then there will be a space for dialogue, for Q&A. Throughout the broadcast, the participants can relay any questions or comments through Zoom or through YouTube. There will be a team screening the questions and relaying them to the panel. Here, we'll be opening for our international speakers and renowned speakers. Hernan Sepulveda is a national speaker, master's in political science from the University of Chile. He's part of the Ministry of Health as a cabinet advisor, and he's the national director in human resources. He's been human resources advisor for health ever since 2010. In 2017, he was an advisor for human resources from the OPS, for PAHO. He will be giving a presentation on regional efforts by PAHO, how they've contributed to motivation and retention of nursing staff. So the floor is yours, Hernan. Thank you, Sonia. Thank you to the nursing school from the Catholic University and UC Christus Health Network for to be able to speak with my fellow countrymen once again, and on this to talk about such an important topic dealing with the profession of nursing. I'll be sharing my screen. Very well. Before preparing myself for this presentation, with Oscar, we went over what they were looking for when putting forward this topic. We went over the need of retention of nursing staff and what the concept of retention actually meant. Now, here the emphasis is that there is a problem with nurses in general who are leaving, not just the public to private or private to public. They're emigrating towards other areas that have nothing to do with health care. So when going over what could account for this phenomenon, which hasn't been studied enough, it's quite a new phenomenon, at least for the rest of the regions in the Americas. And here, when going over the shift systems, the stress, but we also were able to agree on the fact that an essential element for explaining this or accounting for this has to do with how the nursing staff, how nurses are motivated enough in the development or in carrying out their tasks, and to see if they were motivated enough without taking into account the burden and compensation. This would be on the decline, probably. So what we were able to cover in this presentation is how these regional initiatives driven by PAHO can contribute, or how they can contribute to the motivation and retention of nursing staff. Now, this is we're looking at this at a more macro scale. This has to do with policies at large. So the exercise is to see how those orientations or guidelines will allow to approach motivation and the concept of retention of nursing staff. This will be split into 4. First, we'll be looking over an overall regional context, overall and regional context. Then we'll be looking at instruments for the development of human resources for health in the Americas, and how these guidelines can have an impact on the profession of nursing and how it's carried out. And then we'll be looking at 2 key concepts for bolstering retention of professionals and staff. And finally, we'll have some final thoughts. The first has to do with how the WHO looks at human resources in health, because this has to do with the role of human resources for their services. With the pandemic, this has been revitalized, rekindled. It has been posed as having a more significant role than before. Now, this could be a key element. Now, this had been said far before. The health systems can't work without health staff, of course. The coverage of healthcare in the population depends on its availability, accessibility, and acceptability. These 3 concepts, now, these concepts mean that we have to have the necessary amount of human resources, but also with the allocation of those resources, not just concentrated in the large urban areas, but in unattended areas, rural areas, and so forth. And acceptability is for them to have the necessary profile for the work that they need to be carrying out. Along this vein, what would be the context we're in pre-pandemic? Well, it was, of course, exacerbated due to some specific points that we'll be going over. First of all, there is still in our region, in the Americas, a lack of human resources who are qualified for ensuring services, comprehensive healthcare services. So there's a deficit in human resources. There's some countries that have more deficit than others. Chile's situation isn't as dramatic as that of Bolivia, for example, Haiti, and other countries in the region. But there aren't any, maybe with Cuba, perhaps, or Uruguay, except those. Only those would you say that you're comfortable with the amount of human resources on hand? Now, of course, this was all exacerbated during the pandemic. We had to increase our staff through different mechanisms, and the lack of equity and just allocation. Now, sometimes stats can be deceiving. If a country says they have good availability of nursing staff per inhabitants, yes, that might be the case in large cities and urban areas, but in more unattended areas, rural and more dangerous areas within the city, might not be as well covered as the average would state. Now, another interesting topic would be the lack of coherence between the healthcare model that is being implemented, basically based on integrated healthcare networks and the model of education and training in healthcare, we know that today there's still a training specialized in biomedical trainings, specialized on hyper specialization in hospitals, and which doesn't account for the needs that should be covered for healthcare professionals that are coming out. There's a lack of proper financing. Now, due to human resources are seen as a cost by certain governments and not as investment. Often there's a discrepancy between payment among professionals, among subsystems, among countries, which can lead to migration because there's healthcare professionals that are looking for better compensation for their services, and they can look for them in other countries. There's a lack of information and data for decision making. There are countries that can't address their gap in staff because they don't know, they're unaware of their total amount. And the countries that do have data systems, they're perhaps not integrated. For example, Chile has 3 systems, but which aren't totally integrated. Chile has the Superintendent of Health, which is a professional registry from the state guarantees in health. We have information management in human resource management, which is the hospitals, and then we have primary health care, but these aren't well integrated, and this makes it difficult to plan and to calculate needs on the whole. And there's weak governance and stewardship in the sector of health between managers, between associations, universities, and professional associations, guilds. So it's important to improve what we call governance and stewardship. The abilities given to the health ministries or health departments of a given country. Now, there are regional instruments that I'd like to mention. There's more, but these are the ones that are the most current. The strategy of human resources for universal access to healthcare and universal healthcare coverage, which was approved in the Pan American Health Conference, number 29 in 2017. This is a guideline or a guide for the member states for the development of policies and plans for human resources based on the main stewardships of law of all the people who enjoy the maximum degree of health and equity and solidarity. Now, in 2018, in the 56th Board Council of the PAHO, there was a plan of action for human resources for universal access to healthcare and universal healthcare coverage. 10 goals there were established. So with these 3 lines that we'll be seeing, which had the human resources strategy, the action plan in a project carried out with those who are responsible who are in charge of human resources in all the countries in the Americas, put together these 10 priorities. Or what would be the 3 strategic lines? One would be to bolster and consolidate governance and stewardship in healthcare human resources. So the authorities in health departments, they need to have a more active role. They need to have the ability to exert that authority. So access to information systems, planning capability, necessary resource allocation, etc. A second line is to cover the conditions and development of abilities for broadening access and coverage with equity and quality. What WHO was saying. One thing is to have availability of staff, and for another thing, for all communities to have availability. We're talking about distribution with equity and quality distribution. And due to the profile of the health professional that's being trained, the third line has to deal with reorienting the educational sector to respond to the needs of health systems and process of transformation towards universal healthcare. So along these three lines, we had three goals for the strategic lines, four for the second one, and three for the third one. So that leaves a total of 10 as a methodology to monitor this plan. As we do for all the countries in the region, we had several indicators for that. We'll be going over three goals for the first one, governments and stewardship. Here we're talking about posing and implementing national policies and human resources for healthcare. Second is bolstering the capabilities of strategic planning to the workforce. And three is by broadening public investment into human resources and health. These would be the three goals of the first strategic line. The four goals of the second line, you'll see some that are highlighted in bold because they're linked with what we'll be talking about today. One, proper staffing and retention of healthcare staff through development of incentives policy for professionals and an economic incentive policy. Two, interprofessional teams in the first level of healthcare with resolution capability of healthcare problems, with an intercultural focus and with the social determinants in health taken into account. Number three, and this is a large challenge, it's been difficult to put this idea into practice in these countries, in the region, would be three, regulation of the professional work, which allows for activities which allow for the maximum use of competencies of healthcare professionals with the goal of broadening coverage and healthcare qualities. Number four is more directed to the countries in the Caribbean, where due to the brain drain there, since half the nurses there go to other places in Latin America or Canada and the United States. So this also takes into account the wave of immigration from Venezuela. Now the third, along the third line, which is health and education, here there's a high level of articulation between the sector of education and health. But here we're talking about systems for evaluation and accrediting careers in healthcare, which includes standards that take into account technical and scientific competence and social competence of the graduates. There's a first indicator that has to do with the fact that for quality indicators, we need to consider the social mission and the interprofessional education as part of this process in quality standards. And when it comes to competence of the graduate, as mentioned. And number three is a training plan for priority specializations, which takes into account the amount of required specialists for family and community health. So with this orientation, which is quite global, but or general, with the highlighted goals, what's in bold, we can cover two topics which are key here. Two concepts, and from PAHO, which we are pushing forth. Now, in the prior encounter, we talked about some initiatives in APN, Advanced Practice Nursing. So, of course, that would be number one, and interprofessional education, or IPE. Now, starting with APN, or Advanced Practice Nursing, here we have a definition on what we understand as a nurse, an advanced practice nurse. It's an RN who has acquired expert knowledge and skills for complex decision-making and clinical competence for extending their practice. Their characteristics are determined by the context and/or country where they're accredited for performing. It's recommended that they have as a minimum a master's. This is what we understand as APN. Now, what would be the factors that motivate the development of new roles? And you'll remember the second goal from the second line, which was to broaden the competence or the skills in health care professionals. And this is controversial in most countries. We have corporations, especially medical ones, which are a bit, they're very suspicious of this, making this very difficult to get any progress in. Chile has made significant progress if you compare it to other countries, I believe. First has to deal with correcting problems to accessibility to the system. There are areas where we don't have healthcare coverage or there's scarcity of healthcare professionals. So the development of new roles will go towards improving client satisfaction at a reasonable cost, and then improving healthcare with intensive follow-up and counseling in patients with chronic illnesses. Now, this will have an impact in complication prevention and will decrease readmission into hospitals. Another one is to optimize the skills and competency of skills by increasing their responsibility and autonomy or independence. This will increase the finalist response, which is to say the ability to resolve a case in the first encounter. Finally, and this has a lot to do with what we're talking about now, to create work positions which are attractive for nurses. And here we'd be avoiding brain drain or professionals leaving. What would be the results from the experience, that have been seen in APN, Advanced Practice Nursing? Well, there's improvements in access. The users have better access to the services because there's better availability of this professionals in health, and this leads to a reduction or a decrease in waiting times. Their clinical effectiveness is similar to that obtained by physicians. And this is the hot topic as an argument to when it comes to avoiding the development of this kind of initiative. Now, the evidence shows, we'll be looking at a small summary, that the clinical effectiveness is similar, with the difference that it also reduces times and it improves access. There's also improvement in compliance to treatment, management of symptoms in complex chronic patients. There's higher levels of satisfaction. There's more personalized healthcare. It's more oriented towards providing information and more time dedicated towards the time in the medical visit or encounter. We said that it implies risk to patient safety, and I remember who had indicated glasses for refraction. He said, "Well, this is difficult." And Europe, it had been solved a long time ago, and Chile this is also the case recently, and no one can say that an optometrist can't indicate that for a refraction index. There's a lot of countries where they're establishing important roles for APN. For example, there's follow-up programs for chronic patients in health centers and at home, for example, for diabetes, high blood pressure, heart failure, asthma, coronary disease, COPD, dementia. This has been the case in Sweden, England, Australia. There's also management of the demand in mild acute patients in health centers, which is the case in the United States, Canada, Australia, England, Finland, Sweden, Spain. There's also nursing management programs for reducing the volume of patients in medical visits, which are specialized. For example, people with diabetes, asthma, and COPD, or for management of processes in hospitalized patients, with the possibility of management of drugs under protocols. We also have specialized nursing services or departments for the management of cases of people with complex chronic diseases, such as in Canada, the United States, Australia, Denmark, Holland, England. And we also have nurse leadership in programs of transmural healthcare. Now, This is the product of the study of a nurse who has studied all of these topics, who put this all together. So we can see that most of these changes have been implemented in first world countries and developed countries. So the question is, when could this, and this is just evidence, this is evidence of that this worked well. How can this be translated and put into practice in the Southern Hemisphere, in Latin America? Now, we looked at our own national cancer plan, which showed that the nursing schools from the Catholic University of Chile, for example, it could put together a master's program in oncology, which will allow for good management when it comes to the treatment and follow-up and monitoring and prevention with this condition. In Paraguay, when it comes to the pandemic, as we know, there was a strong need for human resources to move a lot of staff, and here, much to the detriment of our other chronic diseases. And in Paraguay, there was a protocol put together for primary care at family health, which allowed for the staff and nursing could look at conventional illnesses or conditions as a supplement to the teams who had emigrated to help with the pandemic. So there's evidence that this can be put into practice and effectively. Another key concept is IPE, interprofessional education, which is considered as a key indicator for measuring quality standards in training in training centers in healthcare professionals in this region. Now, IPE is something that we have been promoting strongly at PAHO. It's an educational strategy which prepares students and professionals in the healthcare area to work in interprofessional teams, optimizing their skills and know-how for efficient collaborative practice. This was formulated or proposed by the WHO in 2010. So IPE is seen as a promising solution for helping to mitigate the deficit in healthcare professionals and a necessary step forward in training them for seeing or dealing with healthcare needs of people and communities at large. So here we wanted to consolidate IPEs, interprofessional teams, So here's a vision of a teamwork of sharing tasks, sharing the workload, not so physician focused this time. And there's evidence that this will improve the resolution capability, especially in primary healthcare, but so that professional healthcare teams can work together. They need to study together. They need to train together. Not just meeting then and there. They need prior training in collaboration. That will no doubt improve their ability to work as a team. This can be very motivating for nursing staff who should also be interacting with other professions, midwives, physical therapists, work between physical therapists, nurses, and physicians. The pandemic highlighted the need for teamwork in between disciplines, especially with critical patients. So here, there's a very important point about the development of interprofessional education to train in a collaborative manner the different disciplines in healthcare. And that requires an effort not just from government authorities, but from universities as well. Now, when does IPE occur? Well, it occurs when members from two or more professions learn about the other, with the other, and among each other. This is a challenge for entities. Here we have the Catholic University de los Andes. There's a lot of people tuning in from different parts, so it's quite a significant challenge. University of Chile and of Concepcion in the south are also progressing, at least in the first lungs, with this challenge. How to implement IPE. Here we have some important points. First off, by creating accrediting standards for professional education programs. That has to do with what we talked about in terms of the goals with quality in education. To design curriculums that incorporate the methodological basis of IPE and the different encounters we've had over the years pre-pandemic. One of the most complex points for moving forward in this initiative was professors or teachers, instructors. That was the hardest. It was the hardest for them to take up this challenge. So it's very important to have that training and to include IPE in permanent education programs and to incorporate IPE in healthcare and education policies. So here we're dealing with the second line, complementary to APN, which allows for better development of the profession. What would be the benefits of applying IPE for progressing towards universal healthcare? Well, it improves the health of the people and of the individuals and access to healthcare. It increases trust, confidence in healthcare professionals. It reduces costs in healthcare. And 4, it improves practices and productivity in the work environment. So the people that benefit are the users here. We're doing this because we want better healthcare. And that means making the most of all of the skills of all of the healthcare professionals. If we make the most of those skills in undergraduate programs with this collaborative vision and with the postgraduate with the APN, besides motivating professional development of the staff, of the nursing staff, we'll be able to attain, importantly, better access to population healthcare. Here's some brief final thoughts. Here, the key concept is motivation. There are 3 components. Here's a study from Capacity Plus on the topic of motivation in healthcare human resources. The first component is our perception of the importance of the work or the job, the importance that we give to it. If we believe that our work is important, our motivation will be higher to continue to develop as professionals. Secondly, our perception of our possibilities of being successful in said work. If we don't believe we'll be successful, we won't be motivated. But if we believe that what we're doing does have an impact, of course, our motivation will be greater. And finally, our expectation of personal reward. And here we're not talking about financial compensation. We're talking about recognition. We'll be enjoying the fruits of our labor. We'll notice who will it have an impact on. These are the 3 elements posed by Mark Luoma in this study about incrementing motivation in healthcare workers. And better motivation leads to better performance, whereas better satisfaction at work leads to better turnover, a reduction in turnover, so better retention. So this is how, with this alignment, this global alignment or general alignment, which should have an impact on the policies of human resources in different countries. Here you could salvage the specific concrete elements to motivate and then to raise motivation in healthcare staff, in nursing, the nursing staff as well, and to mitigate this phenomenon of brain drain that is being produced. So with that, I'm available for the roundtable, and thank you for allowing me to talk about these ideas.
Thank you very much, Hernan. Thanks for the presentations. There are many questions I would like to ask you, and I would tell all of you to write down your questions in the chat to answer them at the end of the presentation. Next, we will introduce our second guest, Nurse Marta Simonetti. She's a midwife from the Catholic University of Chile, 25-year professional experience, master's in advanced nursing practices. She studied at the University of Pennsylvania, and she does research in health institutions with an emphasis in human resources and impact on outcomes of patients. She did PhD thesis, and she's starting a Fondasit project to save the gap in high complexity hospitals in the country. Welcome, Marta, you're recognized. Can you hear me? Yes. All right. Thank you, Sonia, for the invitation to take part in this webinar. Thanks, UC Christus, Red de Salud, that you represent. I'm so happy to be with you today and speaking about a topic that I've been interested in for such a long time. I've been studying on it and I've been doing research about it. And what I'm going to show you is the work we have done between Universidad Los Andes, University of Pennsylvania, and also the collaboration from the Catholic University. I'm trying to pass the slides.
Recuerden de poner sus comentarios.
Please remember to write down your comments and questions on the chat.
Conectada gente de Bruselas, de Uruguay, de Iquique, de Punta Arenas. Ahí está ya la presentación.
Ahí estamos.
All right.
Bueno, a modo general,
In general terms, the problem of nurses' rotation is very important because it goes beyond what happened to the nurse that decides to leave her job. But this is a problem that affects health institutions. This has a detrimental effect on patients and a detrimental effect on nurses, the ones that remain at the institution. And I'm going to tell you what happens with each one of those parties that are related to the rotation. There is a systematic review, which is very recent, that studies the nurse turnover in hospitals. I have to tell you that my presentation has a bias. It is mostly based on what happens at the level of hospitals, which is what I have studied and what has been studied the most internationally. The first thing was the impact of nurses' turnover on patients. And we have to be loyal to the scientific evidence without any bias. The truth is that there isn't such a solid evidence on the impact on patients. In this systematic review, for example, people speak about patient satisfaction. 3 studies were analyzed that assessed patient satisfaction associated to turnover. In just 2 of them, there was a significant relationship. There is another study on falls of patients. Falls increase when there is more nurse turnover. And the same thing happens with a study about the incidence of pressure ulcers. There is a significant relationship there too. Other authors have tried to establish associations with other outcomes, such as medication errors, a hospital stay, accidental extubations, etc. And no significant relationships have been found. However, and this is something I say not because it is in writing, but there is very solid evidence that staffing has to do with the outcomes of patients. It is well known that the nurse turnover produces a reduction in staffing, which can last very long sometimes. So maybe because of the reduction of staffing, there is a negative impact on patients' health. The impact of turnover has been studied, and the health personnel. I'm speaking here about nurse turnover, and there is a relationship between annual turnover rate and mental health problems in nurses. And there are also problems with job satisfaction. Hernan mentioned satisfaction. He used another term that I like a lot, which is motivation or non-motivation. I will speak later about job satisfaction because these are two phenomena that are closely intertwined. Thirdly, we have costs. That is very important. I think here lies the best evidence about the damage produced by turnover. There are very important losses for healthcare institutions. The fact that there is turnover presupposes higher cost in a series of factors that I will show to you in the next slide. But here you can see a systematic review that analyzes the economic impact and non-economic impact as well of nurse turnover. This table you can see costs in different countries. In cases where the currency is not US dollar, it is put in there. When we see that there are cost estimations that are really high, such as Jones, that estimates $82,000, the cost of a nurse leaving the institution. When we think about the estimation of costs associated to turnover, there are several dimensions. For example, what happens with the temporary replacements when there are some positions that are not filled, the cost of the selection process, the cost of hiring a new nurse, orientation and training of a new nurse, because you have to assume that the productivity of this nurse won't be the same as the one that left, who had probably more experience and was much more in tune with the institutions, the costs of contract termination, and all of those dimensions have led to figures that, as we saw in the previous slides, are quite high. In this seminar, we wanted to discuss post-pandemic challenges, and I found a market report done annually in the United States, which has one factor that is very interesting. If you see the last two bars of this graph, what you see is the turnover of nurses in purple, and then the turnover in general in violet. This is over 200 hospitals in the United States. What you can see is that for the first time since this institution has conducted this study, the rate of turnover surpasses the rate of general turnover of health personnel. If in 2020 it was 19.5%, the general rate and 18% nurses. In 2021, it is the opposite. Well, they both increase, of course, and this is probably a consequence of the pandemic. But what's striking is that amongst nurses, the rate starts to surpass all employees. And in this study, I'm sorry, the thing is that I can't see my screen. The estimation of this study is that every nurse that leaves has a cost of $46,000 for the institution. And the mean time for recruitment of a nurse is 3 months. So now, I will tell you what happens in Chile. In Chile, we don't have much data, so I will tell you what, as a research team at the University of Los Andes, University of Pennsylvania have measured. In a large study, including 40 hospitals where there are public and private institutions, we asked nurses whether they would leave their job within this year. And more than 30% said yes. It is a high percentage. In other studies, you see 15%, 25%. Well, this measurement was done in the year 2018. In pre-pandemic, 30% of nurses have said that would like to leave their jobs. Well, this has a second question, which is where they would like to go. Most of them would switch institution. Very few would leave their profession. But even so, it is an important number. Those graphs show where we see significant differences. The percentage of nurses who would like to leave their job is higher in public hospitals as compared to private hospitals. And the percentage is higher in Santiago hospitals as compared to hospitals in provinces. In both cases, differences are significant. This is my personal interpretation. I think that Santiago nurses are more prone to leave their jobs because in Santiago, there are more possibilities to find work. People answer this questionnaire in Angol, Victoria, places that do not offer so many job opportunities. Well, here you can see important differences as far as the intention to leave the job, comparing younger and older nurses. We did a cutoff, those under 35 and those older than 35 years of age. And we found that the younger nurses, this has to do with generational characteristics, younger nurses are more willing to change the job as compared to the older ones. And down below, the graph, which goes hand in hand with age, this shows years of professional experience. Having 10 or less years of professional experience increases. Well, there are more people in that age group who would like to leave their jobs as compared to those that have more years of professional experience. If you see here, I'm speaking not about turnover because we haven't measured it, but here we're speaking of intention to leave their jobs. But many studies have seen that this intention is pretty much correlated with the fact of having actually left the job. So we can work with this indicator and will give us a good idea of what's going on. Along the same line,
formación de posgrado
this is postgraduate and post-title training. The yellow bar,
enfermeras o enfermeros que tienen
nurses that have postgraduate training
en un mayor porcentaje quieren dejar su lugar de
want
trabajo
to leave their jobs at a higher percentage because they think that they could have a promotion because they think they're better prepared.
Entonces,
So
en estos gráficos, lo que
in those graphs, what I want to show you is how we correlate this phenomenon of wanting to leave the job and what's happening in hospitals in Chile.
en el primer gráfico, el que
In the
está
first
más a la
graph,
izquierda, lo que
which is on your left,
relacionando es
we are correlating dissatisfaction, wanted to leave, and right on top, the coefficient, I don't know whether you can see my cursor, but here we have the Pearson coefficient of 0.79, which shows that the correlation is quite strong between being dissatisfied and wanting to leave your job. And there is a very clear correlation, as you can see in this graph. Then there is a moderate correlation between wanting to leave the job and burnout. The coefficient is 0.57, is less strong as compared to dissatisfaction, but there is an important correlation anyway. Then the line, rather than going upwards, the line goes downwards. This is because the correlations are opposite. In the graph down below is environment. I'm going to refer to that in other slides, but environment is moderately correlated with leaving your job. Why does the line go down? Because as environment gets better, there is less willingness to leave. Now, as far as staffing, the correlation gets lost. Here we have a 0.15 coefficient, which indicates that the correlation between wanting to leave and low staffing is practically negligible. And this is something that called our attention in almost all of the analysis we have made of this study. It seems that Chilean nurses recover and can deal with this high burden of work. High workloads. In my PhD thesis, I made an analysis on the influence of labor environment on dissatisfaction, burnout, and wanting to leave your job. And let's take a look at the upper part, where hospitals, well, as a team, we measured the quality of labor environment in hospitals. What you see here is that we classify hospitals such as having poor, average, and good environment. And 37% of nurses that work in places with a poor environment want to leave. 32% of those who work in a place with an average environment want to leave, and 25% in those that have a good environment. So there are differences regarding the quality of the environment. And if we see down below in yellow, in the yellow box, what we see is the probability for a nurse wanted to leave when working in a hospital with a poor environment as compared to a good environment. 1.45 OR. Well, this means that the probability for a nurse to leave if he or she works in a place with a poor environment is 45% higher as compared to working in a hospital with a good environment. And these are results that were statistically significant. What strategies I propose and the literature proposes to deal with burnout, bearing in mind the results I've shown for nurses in Chile? Well, first of all, we have to understand generational differences. In this study by Doles of 2019, they interviewed nurses belonging to different generations, baby boomers, nurses that are about to retire. We practically do not have them in the hospitals because they have already left. And then we have Generation X, and then millennials. I discovered that I seems to be Gen X. We asked them for how long they would stay in their jobs. Baby boomers said as an average 8.25 years. Generation X, much less, 5.8 years. And millennials, 3 years. So quite clearly, we need retention strategies which have to be different because interests are different in these generations of nurses that are coming to work. A second strategy that I found really important, which has to do with motivation, what Hernan mentioned. We have to try and find ways for nurses within the same institution can develop a career, which is not necessarily becoming a boss or something like that, but there are ways to recognize that someone with more years of experience, of someone with better preparation because has done a graduate course or because he's well evaluated by patients, well, that nurse can grow within the institution. This is what Americans call career ladder. So to create this ladder, to try and find the best place for every nurse, enhancing their capabilities within the institution, that they don't have to leave to be recognized. And many things have to be considered: quality of work, years of experience, professional development. It can't be that someone that has been working for 10 years in a unit is in the same working conditions as a nurse that has just joined the institution, because it means that nobody has recognized the value of staying. In the study on hospitals we did in Chile, we asked nurses what are some things that made you dissatisfied. In yellow, you can see the two that appear the most, which are opportunities for advancement in the institution and educational opportunities. And finally, I think it is very important to have positive working environment. In my PhD thesis, I could demonstrate that there is a relationship between the quality of the working environment and the fact that nurses want to stay. It called my attention in social media. I'm not very good at seeing social media, but I've been checking LinkedIn. The number of nurses that tell terrible experiences of poor relationships, ill treatment in their own institutions. And they usually post something. They post why they have decided to leave their job. I think there is a whole area we have to deal with. We need positive interpersonal relationships, that the heads are people who provide support, that are good leaders, that know how to guide, that nurses find workloads that are reasonable. There is a lot of mentoring, especially with the younger nurses or that are just starting. Systems for recognition, orientation programs that are reasonable, that give nurses enough time to learn, to get to know processes within the institution and feel safe, and a lot of interdisciplinary work. Hernan spoke about that. And we could also mention other things, but probably this could be left for the next discussion. Thank you very much.
Thank you very much to both speakers. We'll be moving on to our Q&A, some that have been already coming in. The first question is for Andres. For Hernan, correction. I'd like to know if you recommend any tools for evaluation for motivation that's validated in nursing staff and in terms of job satisfaction, and if you've studied intervention strategies that foment motivation locally in the hospital, understanding that strategies at the national level are outside the bounds of our management. Thank you. In terms of the tools for job satisfaction, there's many, and each one has to correspond to the reality, not just of the country, but the work center. Overall, as Marta was saying, worked a lot in hospitals, but in the doctor's office, it's different. The motivation of a nurse in a private office is different of the motivation of nursing staff at a hospital. Now, there's not really just one tool, but it is important to incorporate these elements to either way to measure satisfaction. What Marta had shown was very interesting. In terms of the interventions, I believe that there's a lot of factors that can be incorporated. We'd already talked about the career. It's a key issue, but not just if there's a career, but if indeed the career is providing a response, a solution to the need of the professional to feel as being part of a process and having professional development. I feel that in Chile, in most countries of the region, there's few healthcare careers. There's little experience, and we have three career models. The medical law, where we have the physicians, the dentists, pharmaceutical, the chemists, pharmaceutical chemists, so forth. And we have a series of levels. We have the administrative statute, which is where most of the staff, the nursing staff, is situated, and primary healthcare. When you visualize that there are three models of personal development which are different, that can lead to frustration, motivation. Once I remember in one of these initiatives many years ago, we tried to assimilate the rest of the health professionals to a similar career model than that of physicians, but sadly, the initiative didn't accrue a lot of support, and there's also a cost issue. The financing was a problem. But these types of careers in nursing staff is part of the administrative statute to try to answer to the needs of hospital work. They aren't that motivating. And in theory, they could be. Here we're dealing with training, performance, there's a qualified experience. But but the performance is never really measured because people don't like negative reviews. Training is not seen as pertinent, and qualified experience is also underestimated. So there's a problem in terms of how this career can be a mechanism that can indeed promote professional development. And these initiatives of how, in terms of how to improve their attributions, so that they feel that to give them more powers, so that they feel that they feel more empowered and that they're solving more problems. So there's an entire world at primary healthcare. There's a great potential for the development of the nursing career as a whole. Thank you. Another thing that you had mentioned that I found striking, this learning together concept with other healthcare professionals. As you said, it's difficult on the professional level to encounter or to have having had such different training lines and disciplines. That's a challenge, and they were very well connected. It's very important to explore, and that creates trust, how to act or the work line. And that was clear from the beginning, and that's helpful for a more participating team, more integrated. It makes the nurses more autonomous. And that's a very important factor when it comes to retention, to avoiding turnover. Now, in terms of what Marta had mentioned, a lot of pre-pandemic trials had shown that we needed at least 6 million nurses worldwide. Post-pandemic, we still haven't imagined the impact that this could lead to in the long term, because when looking at these contingencies, we see a spike, and we're talking about a post-pandemic world, which perhaps in Chile we might have newer spikes, but or not, but this is no longer the exception. It's a way to continue to work. So we'd probably have to reformulate and reinvent ourselves. So we'd have to see the impact and the level of the leadership. And perhaps what would motivate us to act 3, 4, 5 years ago, it would not be the same that motivates us today. Another thing that I see as important is to see, because we've talking about clinicians, of the impact on health outcomes with the patient, but at the level of the leadership, how we need to keep them motivated as well, because often they've been working nonstop during the pandemic to see the impact, because often those good leaders also motivate in their own right. So it's important to motivate our leaders and what strategies we can use to keep them motivated. Another thing that I'd like to mention is that at the level of nursing, we're clear on what the problems are, but my question to the two of you would be how to make the organizations, and this has to be hand in hand with human resources, how to create an understanding or how to value the importance of having a good work environment, not just we're talking about salary, in terms of recognition and policies, and more than a health center specifically. here we're talking about more global general policies. So what strategies or advice would you have? Because we have people that perhaps are tuning in from a public hospital in the south of the country or in the north. What strategy or advice for local ones or specific ones can you give us for us to implement in our day-to-day practice?
Sobre todo porque tú
Well, I can
tocaste
think
el
of, well, since you
mundo de los recursos,
touched
¿no?
on the
Que
topic
son
of
los
resources,
interlocutores al final.
which would be the ones with the voice.
Yo creo que a ese mundo de los recursos uno lo convence
In the world of resources, you can convince them with figures, numbers. So we have to perform a lot of measurements. We have to show that the interventions that you plan and put into practice do have an impact.
No sé, respecto a los ambientes de trabajo.
In terms of work environments,
Todo llevamos, no sé,
we've
de
been
investigación con los hospitales.
we've got 3 decades of research and development with a laboratory in the United States in a magnet hospital, correction, but that doesn't mean that we have to work with them, but we have models that we can reproduce where we know that patient outcomes are better, where we know that retention or of the nurses are higher, where turnover is lower. So to imitate small interventions, to adapt them culturally to our reality of things that can improve the work environment. We have to perform measurements and show that if we are indeed, if we are to invest, that investment will lead to a positive impact. Now, on her words, sadly, the health sector, and well, it depends on other sectors. It depends on other sectors for resources. But when you show that the policies that you propose have effective results or outcomes, it will make it easier to convince your counterparts. So not just the work environment, but the availability and the need to have healthcare staff in different areas. And linking this healthcare outcomes is very relevant. So if we say, for example, that we need strong teams of different professions at the primary level, because this will lower the pressure, take the pressure off hospitals, because 80% of the problems can be solved with these teams trained. This will obviously lead to greater impact. So another significant element that I mentioned when it comes to motivation, when the professional healthcare professionals feels that what they do has an impact. For example, in the case of a nurse, if what they do saves a life or improves the quality of life at the community level, that will evidently lead to a difference in how that person perceives their work. So along that vein, it's not, you don't just have to tell them, well, you can do this and that, but the system should give them all the tools that are required to carry out those new tasks. You studied a lot of cases of medical professionals that go to unattended areas armed with just a stethoscope. So we just refer, which is very demotivational. This has also been seen in other healthcare areas. If you have, for example, I insist on the primary level because that's an area we need to bolster. If we have nursing staff capable of providing follow-up on chronic patients to perform the follow-up with their medication regimen and so forth, with diabetics and so forth, and if we give them all the tools to carry that out, if you can see that the community, and if you can see that the referral rate in the community goes down to the second, tertiary level, well, that person will feel that their work has an impact in the community, and that clearly will lead to a sense of accomplishment. So here we have this new, not so centralized model where everything revolves around the physician might have a positive impact in the work environment.
Súper importante también para lo que han dicho los dos.
Oh, yes, very interesting what you've mentioned. To shed that biomedical model, it might be essential to start with nurse training and education because they were trained for 5 years in a certain way, the standard way. It's very difficult to unlearn. That's one of the main points. Another thing that you covered was another thing you talked about was APN, Advanced Practice Nursing. And this is for both of you because it deals with how to shed or deal with the suspiciousness, the lack of trust. Oh, and we know, but even though there's demonstrated benefits, especially in unattended areas, but we can also see issues where we have restrictions in some countries, important legal restrictions, and we have to be under the supervision, not just supervision, but under a team to guide this APN. So an APN nurse can't work autonomously. So how can we move forward along this line? I believe this is an important developmental pathway, not just to leadership or administrative posts, because that's the most frequently addressed. Something more realistic, how to carry out that investigative line when it comes to country policies. All right, well, first of all, it would be a political decision. If you have a vision of a model where you feel that at the primary level that the healthcare professionals, if you feel that they can have greater resource allocation for problems that always end up being referred to the hospital, ER, and so forth, the governments are the ones that change those kinds of policies. If without the political arena involved, it'll be very difficult to progress. And I believe that the cancer plan, for example, the cancer law or act, there's an underlying political decision, which is very important because here it's not just physicians, but other professionals that can start to carry out tasks in this area. This is singled out to a single area, but this is a good beachhead to continue to move forward. So this also leads to other things in the Catholic University where there's a postgraduate program, a specialization in oncology. So this political decision set in motion a chain of events. So if you apply this to other areas in healthcare, you'll be dealing with a scenario where it'll be easier to develop such an initiative. And secondly, because it's not enough with just policies, because we have corporations, other players, interest groups that will create pressure. The other is the evidence that you've got behind you. And it's very important to show how these initiatives are indeed effective and not a threat, but rather a benefit for the physician, for example. If you ask a physician in Spain, for example, in Andalusia, what they think about this, and they love it because it's another paradigm that they're working in. It's a new one. Because they manage to share information, to share responsibility, which is not just good for the patient, but also for the team. Look at what happened in Paraguay. In Paraguay, since they couldn't, there are difficulties in looking at the most conventional diseases in attending them. They empowered the nurses to deal with those. So we have to see how that experience came out. Perhaps the most likely scenario is that it went out well. Now, often we need to reflect that this is feasible. So there's a lot of initiatives that we have to take because when we don't have enough staff to cover every single part of the country, every nook and cranny, we won't be bolstering our professionals and motivating them. So we need to put the user at the forefront, the community at the forefront, not the interests. from each profession. That would provide a roadmap. Likewise, for interprofessional education, IPE, there's a clear player here, which would be the universities. They're a clear stakeholder. They need to think about how to create reform in their curriculums, which is definitely a need if we are to implement this. Thank you, Nan. Marta, do you have anything to add? Starting with the political policies would be the easiest route. Hopefully this would be the case in our country of how this comes into fruition. But in practice, this wasn't the case. The political decision came after all the evidence that showed that nurses that had started in certain posts at areas of lower access, and that was put into practice in study programs, and then it turned into a policy. I believe that the political decision would be great because it would streamline the steps for this to be put into practice. And when it comes to evidence, we could resort to evidence that comes from other countries, and it'll be a while before we have internal evidence, intrinsic evidence that could point to a greater efficiency in APN, and that we're actually having an impact in a national level. So this is quite a challenge, and it's quite difficult.
Solo para clarificar un poquito el tema de la
And in order to clarify in terms of political decisions, now here I'm talking about the sine qua non decision. It's not a chicken or the egg sort of thing. There's been a lot of progress recently, and I saw what had been done at the Catholic University and University of the Andes, and I see what you've done in APN. But if you are to consolidate a healthcare model, you'll require public policies that bet on that model. Yes, because the problem that we see to train them is difficult, but if we go out to work and they work just as any other nurse, the impact is ultimately be zero. With the current healthcare code, it wouldn't make a lot of sense to continue to train APNs because it won't be work with the clinical community. They'll probably be at administrative posts, but what we need is to resolve more healthcare problems at the community level. So that would be an axis of this, and I believe we agree on that. Well, we don't have time to get to all of the comments. Here we have a comment from a nurse in Portugal. In Portugal, it's similar. Now, there's other comments. We're out of time, so I'd like to thank you for tuning in with us today and going over these topics. There's a lot of challenges ahead. A lot of the people here who have been tuning in, for many of you, the idea is to continue along these lines, to remain in touch, and to develop and share good practices. So, greetings from afar, and thank you for being with us today. Always available for anything you need.
Ahí se cortó.